So, continuing the cells of the central nervous system, we are going to study myelin today. So, what myelin is, it basically is the covering sheath of the axons. It wraps and insulates axons. What does that wrapping do? Is that it may decrease the membrane capacitance. Membrane capacitance is the ability of a membrane to store electrical charge. So, that ability is decreased. That is going to increase membrane resistance. The membrane, it will resist to a change in action potential because it has myelin now. It will lead to increase space constant. What is space constant? Space constant basically is the measure of how long action potential can spread along the neuron until it dissipates. So the space constant is increased definitely if you will have less time constant, which means that it will take less time to change the action potential. The membrane resistance is more, so the charge or the action potential, it is going to spread to a longer area. Okay, and if the ability to decrease is decreased, for example, if you have increased storage capacity, all of the charges, they're going to be stored over here, but and their space constant or their space constant is going to reach here. But if you have decreased storage capacity, it will keep on moving forward because there is not much storage happening, and your space constant or the length constant will increase. That is what myelin do. It basically propels your signal from here to here. Okay, so now how does they conduct fast then? If they are converted, they're covered by myelin, how are they going at a fast pace? It is because of the hero we call nodes of Ranvier. These are the nodes where myelin is not present. Between the myelin chunks, these nodes of Ranvier are present, heavily rich or nourished with the sodium channels. They are going to help with the conduction velocity. So increase conduction velocity of signal transmitted down axons, which is called saltatory, meaning dancing conduction of action potential at the nodes of Ranvier where there are high concentration of sodium channel. Now where are we getting myelin from in central nervous system? In central nervous system, we are getting it from oligodendrocyte, and in peripheral nervous system, we are getting it from Schwann cells. All right. So central nervous system is oligodendrocyte, and peripheral nervous system is Schwann cell. All right. Now, what are Schwann cell and what are oligodendrocyte? These are the two cells that are, you can say that, synthetic machines for producing the myelin. First of all, Schwann cells are in the peripheral nervous system. These over here are the nucleus. This is the Schwann cell. This is the myelin sheath that is being produced, and between the myelin sheath, we have nodes of Ranvier rich in what? Sodium channels. Now, what do? They promote axonal regeneration, and they're derived from neural crest. Schwann cells, they are derived from neural crest cells. Now, each Schwann, one cell myelinate only one peripheral nervous system axon. They're injured in Guillain-Barré syndrome, and the marker of Schwann cell is S100. S for Schwann and S for S100 is the marker. So Schwann cell marker is S100. They're injured in what? Guillain-Barré syndrome, which is mainly caused by Campylobacter jejuni, and it causes ascending paralysis and loss of reflexes. All right. So Schwann, one cell, it myelinates only one peripheral nervous system. Moving towards oligodendrocytes. Now, this is the node of Ranvier. This is the axon. In it, over here, we have a big oligodendrocyte, and you can see that it is covering more than one cell. Okay. Over here, Schwann cell only covering one myelin. One oligodendrocyte, you see, it is covering this, and it is covering this, and it is covering this. So it is multiple. It is myelinating multiple axons. Okay, so myelinate axons of neuron in central nervous system. Each oligodendrocyte, it can myelinate. Move forward. Each oligodendrocyte, it can myelinate many axons up to 30, and it is a predominant type of glial cell in white matter. Now, they're derived from where? Again, neuroectoderm. Schwann cells derived from neural crest cells. Oligodendrocyte, central nervous system, derived from neuroectoderm. They have fried egg appearance histologically. Over here, appearance like this. Injured in multiple sclerosis, the diseases which are going to injure your central nervous system are going to injure your oligodendrocyte. Multiple sclerosis, multifocal leukoencephalopathy, leukodystrophies, all of these are going to destroy your oligodendrocyte. Otherwise, the disease of peripheral nervous system, Guillain-Barré, it is going to destroy your Schwann cells. So these basically are your cells which are present in your central nervous system. Myelin cell, which is made by Schwann, and oligodendrocyte. Myelin, sodium channel, Ranvier rich. Schwann cell, peripheral nervous system, made up of neural crest. Oligodendrocyte, central nervous system, multiple axon, and they're derived from neuroectoderm. Okay. Next, we are going towards the physiology of your central nervous system. Okay, now when we move toward the physiology, this is the neuron action potential, and many questions are going to come from here. So if you're going to understand this well, you're going to ace many questions that you're going to see on your UL or on your final exam. All right, so first we are starting with the resting potential. First we'll start with the resting potential. So the resting membrane potential in here, over here, membrane is more permeable to potassium than sodium at rest. That means you're going to have more sodium, you're going to have more potassium over here than sodium. So voltage gated sodium and potassium, they're both closed, you have more potassium inside, so that is why you are at the resting potential. This is the normal rest. Cell is resting, and during its resting potential, membrane, it is very permeable to potassium. Okay, now what happens is that suddenly a signal comes and that opens your sodium activation gate. Like some signal come knocking at the door, and the first gate that it finds is the sodium gate. So that gate opens and sodium, it flows inward. This is what is happening over here. Normally what was there, that cell was very good with the potassium, but cell at resting potential was not letting the sodium in, because when sodium will come in, no rest is going to happen after that. Okay, the cell, when it is doing some peacetime, having some me time, it doesn't let the sodium in. Sodium is out. Sodium keeps talking, but it is out. But when sodium comes after crossing a certain threshold, it comes with power, it comes with energy. Sodium gate has to open. Cell has to open those sodium gates. And when cell open the sodium gate, sodium, it comes in, it flows inward. And when sodium flows inward, there will be more positivity inside the cell, and the threshold or the membrane potential will go upside. It will go more on the positive side. Next, what happens is that when cell has allowed enough sodium to be in, cell is like, I am exhausted now, I am enough, I am done with the sodium and your signals, I am going to close my doors now. Then cell again closes its door to sodium. What happens is that sodium, it inactivation gate closes at peak potential, thus stopping sodium inflow. Potassium activation gate opens, and potassium, it flows outward. Now what happens after that is that this potassium, it opens during the third phase of neuron action potential, and the cell is like fed up of everything. It is closing the doors for sodium, and it is asking potassium to kindly leave. All right, now when the potassium is going out and sodium is not getting in, the membrane potential will decrease. Obviously positive is going out, no positive is coming in, there will be negatives inside here. So the membrane potential will come down, and this threshold will come towards negative side. What happens at the fourth stage is that membrane hyperpolarization. Now potassium activation gates, they're very slow to close, so there is going to be excess potassium efflux and brief period of hyperpolarization, which is this. Like this is the resting potential, but cell has gone so crazy that it has gone even down to the resting potential by the opening of potassium channels, and then voltage gated sodium channel, they switch back to the resting state, not allowing the sodium to get in, and sodium potassium pump, they restore the ion concentrations. Okay, they restore the ion concentration via managing the ions to the point that they get slightly positive after, for not positive, comparatively less negative. Okay, and then they again reach their resting potential. So what do we learn from here is that the cell was resting, sodium gates closed. Suddenly a threshold comes, sodium gate opens, positive upstroke of the membrane potential, and after cells get exhausted, it closes the sodium door, and it asks potassium to go out as well. Now in its deal to move the potassium, to get the potassium out, a lot of potassium has gone out, and that causes what? That basically causes hyperpolarization of the cell, and that hyperpolarization will cause this over here, and then after some time the cell will recover its normal state. So that is about the neuron action potential. All right, now next we are studying we are moving towards what? Next we are moving towards over here, sorry for this, sensory receptors. Now these are the receptors which are responsible for giving you the senses, or giving you the feeling that basically you feel to carry on with the life. First of all, we have free nerve endings. Now the neuron fiber type which is present in these free nerve endings are A sigma, fast myelinated fiber, A class, very fast, C low class, like C class, slow, unmyelinated. Okay, and A delta plain, it is fast but attacks is slow, but C is slow. Okay, A delta, it is again fast. Next, we have all tissues except your cartilage and islands. They have free nerve endings. Every tissue in your body have free nerve endings except the cartilage and islands. They don't have it. And they sense pain and they sense what? They sense temperature. Next, we have the Meissner corpuscles. They are large, they are myelinated fibers, and they adapt very, very quickly. Meissner's mega, you can remember it from mega. Meissner mega, large myelinated fiber. Meissner mega, they're big, and Meissner myelinated, okay? They are present on glabrous, hairless skin like your palms and soles, all right? And they are dynamic. They experience fine, light touch, low frequency vibration. They detect those vibration, and they know that skin indentation is also felt by them. Next we have is the Pacinius corpuscles. Pacinius is also big, and they're also myelinated, and they also adapt quickly. So these are same in their sensory neuron fiber type. They are present in deep skin layer, ligaments and joint. Pacinium, they go deep, very, very deep, okay? They're not superficial. So they go into deep skin layers, ligament and joint, and they in high frequency vibration and pressure. So Pacinium is for pressure. Pacinium or pressure is definitely going to be high frequency. Next we have is the Merkel disc. Now Merkel discs, they are large again, they're myelinated, but they adapt slowly. Merkel is like the kind of guy who's Merkel lousy, so he's slow. So Merkel, they adapt slowly. They have sustained response to pressure. They're present in fingertips and superficial skin. And Merkel disc, like next time you see a fingertip, you should remember that, oh my god, there are a lot of Merkel disc in here. They experience pressure, they experience deep static touch, for example, shapes and edges. You can touch the shapes and edges of certain things, and you can get to know that what kind of shape is present over this thanks to your Merkel discs. Next we have is the Ruffini corpuscles. They are large, again, they are myelinated fibers. They're intertwined among collagen fiber bundles, and they adapt very, very slowly. Again, Ruffini is a friend of Merkel. They're both adapting very slowly. They're both present of fingertips, joints, and they sense stretch, joint angle change. The one that is present in joint is Ruffini. Like, rheumatoid is a part of joint problems. Ruffini, rheumatoid, joint angle change. Okay, stuff like that. Sorry. Okay, so sensory receptor, we have free nerve endings everywhere except islands. Large, we have types of free sensory nerve endings. Alpha C, Meissner, large. Pacinium, Meissner, hairless skin. Pacinium, deep skin layers. Merkel disc, fingertips, slow to adapt. Ruffini, joints, fingertips, and slow to adapt again. So these are about the sensory receptor there that are present. Next we have how we are going to study the structure of peripheral nerve. So what are we going to study in peripheral nerve is that peripheral nerve is multi-layered structure. Okay, over here we have endoneuron, which you can see over here. It is very thin. It has supportive connective tissue that ensheaths and support individual myelinated nerve fibers, and it might be affected in Guillain-Barré. Again, Guillain-Barré is a disease of peripheral nervous system. So what gets affected in Guillain-Barré? Endoneuron, the innermost layers get affected in the Guillain-Barré syndrome. Next, after endoneuron is a perineuron. It is basically a blood nerve permeability barrier. Perineuron, permeability barrier, and it surrounds a physical of the nerve fiber. A physical of nerve fiber, it is surrounded by perineuron. Above the perineuron you see is epineuron. It has dense connective tissue that surround the entire nerve, both blood vessels and vesicles. So first thing that a nerve has is blood vessel, and it is surrounded by endoneuron. Next we have is a vesicle, which is by perineuron, and then the whole nerve is by the epineuron. So endoneuron, this is the nerve fiber, endoneuron, then perineuron, then epineuron, and all of it is the nerve trunk of peripheral nervous system. Okay, now next we have is a phenomenon from which you're going to see a lot of questions. That is, excuse my notes. It is chromatolysis. Lysis means breakdown, chromatin means chromatin DNA. Now what happens here is that it is a reaction of neuronal cell body to axonal injury. Changes that reflect increased protein synthesis in effort to repair the damaged axon. It is characterized by rapid cellular swelling, displacement of nucleus to... Alright, so in this what you need to remember is there is a kind of degeneration which we call Wallerian degeneration. It is the disintegration of axon and myelin sheath distal to the sign of axonal injury, with macrophages removing the debris. So what happens at the site is chromatolysis, but what happens distally is Wallerian degeneration. Proximal to injury, what happens is that the axon, it retracts, the cell body sprout new protrusions that grow toward other neurons for potential reinnervation. It serves as a preparation for axonal regeneration and functional recovery. Now over here is happening chromatolysis in response to an injury. There is round cellular swelling. You can see the displacement of nucleus to periphery, because cell is like, nucleus bro, you go to the periphery, let me fix all this situation. And then you're going to see the dispersion of nasal substance, which is lysis in the word means, dispersion of nasal substance. Along with it is happening, this is axonal retraction. This is the site of damage, and distal to that site of damage is happening what? Wallerian degeneration, in which myelin debris you can see over here and microglia infiltration will happen in order to fix that place. Axonal reaction over here, what do we have? Swollen rounded cell body, nucleus is displaced to periphery, nasal substance dispersed throughout cytoplasm. This is axonal reaction. But when these reaction not fixed in time leads to irreversible injury, what will it do? It will shrink the neuronal body. It will cause deep eosinophilia, and you will have loss of nasal substance. That is how you differentiate an irreversible injury from axonal reaction. Swelling is good, shrinkage is bad. Okay. Another concept over here is that during trauma, you would have the transfer to brain force. You will have shearing of white matter tract. There would be secondary biochemical changes, which we call axonal degradation, and normal axonal transport will be inhibited. You're going to have accumulation of protein, which are transported by axon, MLI precursor, and alpha synuclein. Obviously, when axon is not working, anything that would be transported by axon is going to get increased in its quantity. So that over here is chromatolysis. The take-home point is you should know the difference between axonal reaction, irreversible injury, and Wallerian degeneration, which is going to have myelin debris and microglia infiltration in it. All right, next we have are the very important nitty-gritty details regarding central nervous system. Whenever we study central nervous system, these are the things that are going to be asked or going to be tested a lot. So neurotransmitter changes with disease. First, neurotransmitter, you also need to know the location of the synthesis, because sometimes the question will go like, okay, the neurotransmitter that was synthesized in this part of the brain, for example, in locus ceruleus is decreased. Tell me, what is the enzyme responsible for this? And I'm like, what? Because you have no idea where these neurotransmitters. Okay, next we have is we were studying dopamine. Dopamine is decreased in depression. We know that schizophrenia is a very hyperpsychological state. We have it increased in schizophrenia. We have dopamine increased in both Huntington disease, and we have it decreased in the Parkinson disease. So in Huntington disease, because in Huntington disease we have chorea, we have ethetoid movement, so they're also similar to that of like hyperactive state. So we have more dopamine there. Next we have is the GABA. GABA is by basal ganglia, GABA ganglia, and it is nucleus accumbens of. So GABA is an inhibitory neurotransmitter, so you can remember it as accumbens. It resembles numbness. Numbing is also inhibiting. So GABA is synthesized in nucleus accumbens. Anxiety, it is decreased. It is inhibited. So anxiety, it is decreased, and in Huntington disease, it is also decreased. Inhibitory is decreased. That is why your body hyperactive. Anxiety hyperactive, you get inhibitory decreased. Next we have is norepinephrine. Norepinephrine is synthesized in pons in locus ceruleus. Anxiety, norepinephrine is increased. Hyperactive state, depression, it is decreased, because it also is like hyper or happy hormone. Okay, next we have is the serotonin. Serotonin is in brain stem RAF nuclei. RAF is resembling laugh. So serotonin, happy, laugh. So RAF nuclei, which is present in the brain stem, it is decreased in anxiety. That is why you have anxiety, because you have less happiness of serotonin. Okay, it is decreased in depression, and it is decreased in Parkinson disease as well. So what you have to remember is acetylcholine, basal nucleus of Maynard, master Maynard. Dopamine, ventral tegmentum or midbrain. Nucleus is nucleus accumbens. GABA, basal ganglia. Norepinephrine, locus ceruleus, pons. Serotonin, raphe and brainstem. And these are the things that we're going to study in the diseases as well. But from here, what you have to remember is the location of synthesis. All right. So acetylcholine, dopamine, GABA, norepinephrine. Moving forward, we're going to study beautiful sun has reached the window. Okay, in meninges, what are meninges? This over here is your dura mater. These are the bridging veins. This is arachnoid matter. This is biomatter, and this is brain. So covering of the brain is your meninges. There are three membranes that surround and protect the brain and spinal cord. First is dura mater. It is the thick outer layer closest to the skull. It is derived from the mesoderm. This is the skull, and closest to the skull is dura mater. Dura is with durability. So whatever is thick is durable, and whatever thick is with the skull, which is very powerful. So dura mater is with the skull, outermost layer. Next we have is arachnoid matter. It is the middle layer, and it contains web-like connections in it, and it is derived from neural crest. But what important is that CSF, it flows in your arachnoid matter. All right. So arachnoid is derived from the neural crest because CSF it flows from here. Neuromatter is just for protection, so muscle, mesoderm, spleen, they're all derived from mesoderm as well. Next we have is the pia mater. It is thin, it is fibrous inner layer that firmly adheres to brain and spinal cord. It is derived from a neural crest as well. Okay, so pia mater is thin, it is innermost. Obviously brain is so delicate and fragile, there should be something very thin fibrous band that should cover it, and after you thinning the thickness, it gradually increases till it reaches the dura mater. All right, so CSF it does flow in the subarachnoid space located between arachnoid and pia mater. What is epidural space? Potential space between dura mater and skull vertebral column containing fat and blood vessels. Site of blood collection associated with middle meningeal artery injury, and middle meningeal artery is when your pterion is affected, which is the connection point where all the lobes they meet in your skull. Okay, so this is about the meninges. Next we have about meninges, you have to keep this in mind that dura is from mesoderm, rest of them are from neural crest cells, and meningitis is caused by certain bacteria. Okay, viruses, fungus, a lot of stuff basically, and there's also aseptic meningitis. So your meninges, they get inflamed by literally anything. Next we have a very important brain protection, like brain, the thing that gives brain this protocol is the blood brain barrier. Not everybody can enter it. So this is the tight junction, this is the basement membrane, this is the capillary lumen, and these are the astrocyte foot processes, and together they make the blood brain barrier. What it does, it prevents circulating blood substance, for example bacteria, drug, from reaching the CSF, CNS. It is formed by four structures, because if anybody we eat is going to be in the brain, it is going to create a lot of mess. So blood brain barrier is there to protect you. That is why boundaries and barriers are very, very important. So four structures, what are those four? Tight junctions, definitely they are between the non-fenestrated capillary endothelial bud, so things could not enter. Basement membrane, pericytes are the cells of blood-brain barrier, and astrocyte foot processes. Glucose and amino acid, they cross slowly by carrier-mediated transport mechanism. Non-polar lipid-soluble substance, they can cross rapidly via diffusion, and glucose is needed for brain to work. Next we have is the circumventricular organ, the organs that are present around the ventricles with fenestrated capillaries and no blood-brain barrier. They allow molecules in blood to affect brain function. For example, if you're like, okay, there's a blood-brain barrier, but there are things that do affect your central cerebrospinal fluid, they do affect your CNS. How does that work? This is the reason how they work. Area postrema, which is the vomiting after chemotherapy. It is organum vasculosum lamina terminalis, are the osmoreceptors which are present in here, or neurosecretory products to enter circulation, neurophysin, etc. They are present. What happens is that this does not have a blood-brain barrier, so whatever you have in the blood is exposed. This area is exposed to that, and if it is problematic, it will definitely cause problem, because these are the things, they do not have blood-brain barrier. Disruption, for example, in stroke, it leads to vasogenic edema. Hyperosmolarration, for example, mannitol, it can disrupt the blood-brain barrier. It will increase the permeability of medication, and it will also decrease the intracranial pressure. Other no blood-brain barrier areas alongside your area postrema, the pituitary gland where oxytocin and ADH is released, and pineal gland. These two glands, they also do not have any blood-brain barrier. Pituitary gland and pineal gland. What you have to remember is that it is made up of capillary, it is made up of basement membrane, pericyte, astrocyte foot process, and capillary endothelial cells. All right. Next we have is the vomiting center. Okay, so vomiting center is coordinated by nucleus tractus solitarius in the medulla. It is controlled in the medulla. A lot of stuff is being controlled in the medulla, which receive information from the chemoreceptor trigger zone, which is located inside area postrema, puke strema, in the fourth ventricle. Now GI tract via the vagus nerve and vestibular system and CNS. These are the places from where vomiting center is going to get the signals, and that is going to affect your body. Now chemoreceptor trigger zone and adjacent vomiting center nuclei receive input from 5 major receptors. You need to know these receptors to know the mechanism of action of anti-emetic drug. Histamine, H1, domperidone, etc. Muscarinic, M1, neurokinin, apretitin, dopamine, D2, it is domperidone, and metoclopramide, and serotonin 5-HT3 is also anti-serotonin, helps it. Okay, so these are the 5 receptors. 5-HT3, D2, and NK1 antagonists, they used to treat chemotherapy-induced vomiting, and H1 and M1 antagonists treat motion sickness. H1 antagonists treat hyperemesis gravidarum, which is the exaggerated nauseous feeling during your pregnancy, particularly when you are pregnant with twins. It happens over there. Okay, so in vomiting center, you have to remember that it does not have a blood-brain barrier, and moreover, what is there is that there are the 5 receptors that trigger your vomiting receptor: HT3, T2, NK1, H1, and M1. H1 and M1, motion sickness. H1 alone, hyperemesis gravidarum. Rest of these 3, like complicated type of receptors, obviously we're going to treat the complicated chemotherapy-induced vomiting. Next we're going to study is sleep physiology. Very important. You're going to see many questions coming from sleep physiology, and you're going to high chance you're going to mix a lot of them. So today we'll complete sleep physiology, and that we'll call it a day. Sleep physiology: sleep cycle is regulated by circadian rhythm, your day and night rhythm, which basically is destroyed when you use phone and sleeps in the day and stay up in the night. What is driven by sound like an Asian mom right now. What is driven by suprachiasmatic nucleus, suprachiasmatic of the hypothalamus. Circadian rhythm, it controls nocturnal release of ACTH, prolactin, melatonin, norepinephrine, and this nucleus release non-epinephrine release into pineal gland that will increase melatonin. So is regulated by environment. Chiasmatic nucleus, it is regulated by environment. For example, light. After you close your lights, norepinephrine will be released. It will stimulate pineal gland to release melatonin, and that is how you sleep. We have 2 stages of sleep: rapid eye movement, REM, and non-rapid eye movement. Alcohol, benzodiazepines, and barbiturates, they're associated with decreased REM sleep. Over here is the REM sleep, rapid eye movement, decreased REM sleep, and M3 sleep, the third part of non-rapid eye movement. They're going to decrease these, and norepinephrine also decreases the REM sleep. It affect all of these. Okay, benzodiazepine, they're useful for night terror and sleepwalking, because night terror and sleepwalking, it happens in N3 and the REM sleep. So when you decrease those parts of the sleep, you're going to help with the night terror and sleepwalking. Okay, now first we need to understand these 4 stages, and then we'll able to understand benzodiazepine, effect of benzodiazepine and barbiturates more on the sleep. First we have is non-REM sleep. Over here is non-REM sleep, and over here is REM sleep. First we are awake. When we are awake, we are active, alert, active mental concentration. We have beta waves, the highest frequency, lowest amplitude. Beta, like there is some frequency that telepathy happens through beta rays. So obviously telepathy is going to happen when you're up and awake. So beta rays when you're awake. When you're awake but you have your eye closed, you have alpha waves. Okay, so open your eyes and think of beta rays, close your eyes and think of alpha rays. Okay, now here is where the actual game starts: non-REM sleep and the REM sleep. Now the non-REM sleep, which makes you 75% of the total sleep, is further divided into 3 stages. It is non-REM, that is why it is further divided into N1, N2, and N3. Now N1 is the light sleep, when you are like about to sleep, not properly slept and not properly awake, and the ECG waveform is theta. You're going to have theta slowly being there. Okay, theta is basically the bus which you take in order to go into the deep sleep. Next is the stage 2, N2, which have 45% of your sleep. It is in deeper sleep when bruxism, that is tooth grinding, occur. N2 tooth grinding occur. Sleep spindle and K complexes. Now ECG waveform, we have 1 ECG waveform over here, but over here N2 we have 2 types of it: potassium K complexes and not potassium. Okay, K complexes and sleep spindles, 2 waveforms, and tooth bruxism. Okay, N3 25%. It is the deepest non-REM sleep, slow wave sleep, sleepwalking, night terrors, and bedwetting, because it is the deepest form of sleep. You have no idea what you are doing, so it is happening in N3. Delta wave, lowest frequency, highest amplitude, deepest sleep state. Okay, so delta is associated with what? Deepest sleep stage, and it is the N3, 25% of your sleep. Non-REM, after non-REM you have REM. In REM sleep, which is 25% of your sleep, you have loss of motor tone, increased brain oxygen use, because we will get to know why increase oxygen use after here. Variable pulse, blood pressure increase, acetylcholine. REM is when dreaming, nightmares, and penile clitoris tumescence occur. That is why increased brain oxygen use. It may serve memory, processing function, increase oxygen use. Extraocular movement due to activity, increase oxygen use of PPRF, paramedian pontine reticular formation conjugate gaze center. It occurs every 90 minutes in duration. It increases throughout the night. Like first REM sleep every 90 minutes, then it increased after the next 90 minutes. Okay, Okay, so that is your REM sleep, and it again has beta. So you do stuff that is like dreaming. In dreaming, you feel like you're awake. Nightmares, you feel like, oh my god, I was awake. I feel as if it really happened to me. So it is very much similar to the waveforms of your awake open eye. So beta. Changes in older adults. When you get old, what happens is that your REM sleep goes down. So you are not going to have much of the dreams and nightmares. As you get old, there would be the decreased deep sleep, because there won't be any need as well. You would have increased sleep latency. What does mean by sleep latency? Increased time taken to go into the deep sleep, and you would have early awakenings. Changes in depression. What will happen in depression is that increased REM sleep time. In depression, you see nightmares. In depression, particularly in PTSD, you're going to have the flashbacks of that event. So your REM sleep time will increase. REM latency will decrease. That means you're going to jump into REM very, very fast. N3 is decreased in depression. You don't get enough deep sleep. Repeated nighttime awakenings are there. Early morning awakenings are also there if you have terminal insomnia. Terminal insomnia is that awakening by the end of the night. Changes in narcolepsy. Narcolepsy is a disorder in which you lose tone out of nowhere and there's difficulty in sleeping, and there they also will be decreased REM latency. You're not going to jump into REM very fast. And at nights, okay, bears drink blood. If you want to go with the mnemonic, otherwise there's no need. So sleep time taken too late. Okay, so we have covered sleep physiology. The first thing is that it is controlled by circadian rhythm, and it is driven by suprachiasmatic nucleus, which will release norepinephrine. That norepinephrine will trigger pineal gland, and melatonin will be released. Next we have 4 cycles, but basically we have 2 cycles over here. If you can see, if I can move it forward, this is what happened. This is the sleep cycle, and 1 is the 5%. These 3 are non-REM sleep. 5% of the sleep, your like theta waves are there, and it is a very light sleep. N2 is a deeper sleep. N2 bruxism helps here, and K complexes and sleep spindles, you can see it over here, tooth bruxism. N3 is a very, very deep sleep, and night terrors and bedwetting and stuff like that, it happens in N3. REM is 25%. Dreaming, sleepwalking, not sleepwalking, but dreaming, and your penile clitoris, tumescence, all of these things happen over your REM sleep. The questions that most often comes is from here. They are from here. From older adult, deep sleep is decreased, quality is decreased, even they dream less because they've spent their life, so REM will be decreased, latency will be increased, more time. In depression, REM sleep time will increase because depressive people have more dreams, more nightmares, that is why increase, and they will jump straight into it, so latency will also decrease. Okay, whatever disorder, N3 is going to sleep, because if you have less N3, that means you're not going to get enough sleep. All right, so that is it for today. For tomorrow, we'll start from hypothalamus and move forward. Till then, good luck with your studies.